Bismillah ar-Rahman ar-Rahim. Diabetes mellitus and anti-diabetic. The pancreas. Pancreas is an organ that containing 4 types of cells. These cells, according to their abundance in the pancreas, include beta cells, which secrete insulin, which is a storage and anabolic hormone, and also they secrete amylin. Alpha cells, which secrete glucagon. Glucagon is a hyperglycemic hormone that mobilizes glycogen stores. Delta cells secrete somatostatin. F cell or BB cells, which secrete pancreatic polypeptide, involved in the digestive process. Diabetes mellitus is a group of metabolic diseases characterized by chronic hyperglycemia, abnormal metabolism of glucose, lipids, carbohydrate, and proteins. It's considered as an endocrine disorder that associated with abnormal insulin production, impaired insulin utilization, and insulin resistant, tissue resistant. Either one of these will present, or both abnormal production and impaired utilization of insulin. Diabetes mellitus is characterized by chronic hyperglycemia with long-term damage, dysfunction, and failure of various organs, including the eyes, the kidney, nerves, heart, and blood vessels. It has been found that the leading cause of heart disease, stroke, adult blindness, and non-traumatic lower limb amputation. Clinical characteristic of diabetes mellitus: usually fasting hyperglycemia, arteriosclerotic and microangiopathic vascular disease with nephropathy, which is a complication of diabetes. Etiology and pathophysiology of diabetes mellitus. Normal insulin metabolism. Insulin is produced by beta cells in the islets of Langerhans of the pancreas. The main function of insulin is to facilitate normal glucose range of 70 to 120 milligram per deciliter. So insulin is secreted during the day with peaks of increase in the insulin secretion during eating. That's at breakfast, at lunch, and at dinner. Classification of diabetes mellitus. Type 1, we have about 4 types of insulin diabetes mellitus. Type 1 diabetes, which is known as insulin dependent diabetes. Type 2, non-insulin dependent diabetes. Type 3, other causes. Type 4, gestational diabetes mellitus. In type 1 insulin dependent diabetes, there is no insulin secreted, and the patient should take insulin replacement. Type 2, non-insulin dependent diabetes, treated mostly with drugs. Type 3, type 4 is gestational diabetes mellitus associated with pregnancy. We will start with type 1 diabetes mellitus. In type 1 diabetes, there is selective destruction of beta cells, and there is severe or absolute insulin deficiencies. Due to the destruction of beta cells, there is no insulin secreted from these cells. This type of diabetes occurs in younger people, about 30 years of age at the time of diagnosis. Insulin, this group of patients require insulin replacement therapy. Interruption of insulin replacement therapy may lead to a condition known as diabetic ketoacidosis or death. Etiology of type 1 diabetes. It may be due to autoimmune disease that result in selective destruction of beta cells secreting insulin by the T cells, or formation of circulating antibodies against the beta cells. Second, may be genetic. It has been found that diabetes mellitus has a genetic line in 15 to 20% of individuals. Environmental factors such as viral infection, such as mumps, rubella, and cytomegalovirus, or nutrients such as cow milk given to the babies. The babies are given cow milk, which contain antibodies against cow insulin, which resembles human insulin. These antibodies may attack beta cells secreting insulin, leading to decrease in insulin secretion. This slide shows the type 1 diabetes mellitus, where normally beta cells, insulin producing cells, producing insulin, secrete into the bloodstream. So in type 1 diabetes mellitus, these cells are destroyed. So there is no insulin secreted from these cells. Type 1 diabetes is less common than type 2. Etiology may be due to viral infection that lead to destruction of beta cells. Genetic predisposition. It has been found about 15 to 20 people's diabetes has a genetic link. Autoimmune disease that lead to the destruction of beta cells by the immune system. This type of diabetes is characterized by absolute insulin deficiency resulting from diminished beta cell mass, leading to low levels or no insulin in the blood. And the net result is hyperglycemia or increase in the plasma glucose level. As you can see in this graph, type 2 diabetes mellitus characterized by decreased insulin production from the pancreas, which will lead to hyperglycemia, increased hepatic glucose production, that's stimulation of gluconeogenesis and glycolysis, decreased glucose uptake in the muscle and fat tissue, increased glucose reabsorption in the kidney, decrease in creatine effects in the GIT. All will lead to decrease in the utilization of glucose with an increase in the glucose blood level or hyperglycemia. Type 2 diabetes mellitus, there is affects fat metabolism. It also affects the fat metabolism, leading to increase in the concentration of free fatty acid and triglycerides level, with decrease in high density lipoprotein cholesterol level. Ketoacidosis rarely occur with type 2 diabetes. It may be due to stress, infection, or use of drugs that enhances resistance to insulin action, such as corticosteroid. Non-ketotic hyperosmolar coma, more common with type 2 diabetes. It's a life-threatening condition characterized by hyperglycemia and dehydration that occur in poorly controlled type 2 diabetes. As we said before, type 2 diabetes is associated with either impaired action of insulin or dysfunction in beta cells. As a result of impaired action of insulin, this will lead to increased production of glucose from the liver and decrease utilization of glucose in fat and muscles. As a result, it will lead to hyperglycemia. The other cause or consequence of type 2 diabetes is that there is beta cell dysfunction or death, leading to decrease in the insulin secretion from the pancreas. So insulin is produced in small amounts and able to utilize the glucose. Etiology of type 2 diabetes. In type 2 diabetes, response to insulin is decreased, so there is decreased peripheral utilization of glucose in muscle and fat tissue, with as a result with an increase in hepatic glucose production, because these tissues were unable to take the glucose found in the blood, and the body get a notice that glucose is not enough for to be utilized by muscle and fat. To compensate for this, the body try to increase the hepatic glucose production through gluconeogenesis and glycolysis, increasing the plasma level of glucose. The mechanism of insulin resistance is unclear, but may be due to both genetic and environmental factors or post-insulin receptor defects. That is, insulin will bind to the receptor but unable to exert its effect and remove the glucose from the body, from the blood to the tissues. Increase in hepatic glucose output is a characteristic of type 2 diabetes mellitus, and it's due to decrease in insulin. The decrease in insulin secretion lead to an decrease in the inhibitory effect on glucagon secretion, so glucagon will be released, which will act on the liver, stimulating gluconeogenesis and glycolysis, both which will increase the plasma glucose level. As we said, type 2 diabetes is characterized by an increase in plasma level of glucose and decrease in glucose uptake in the tissues such as the muscle and adipose tissue. In the muscle, the decrease in insulin secretion in type 2 diabetes lead to decrease in glucose and amino acid uptake, with an increase in protein muscle breakdown. This will lead to increase in plasma glucose, increase in plasma amino acid due to the breakdown of protein of the muscle. In adipose tissue, the decrease in insulin secretion will lead to increased lipolysis and decreased lipogenesis. This will result in an increase in blood fatty acids. This picture shows how the plasma level of glucose is regulated by the body. Mainly, the plasma level of glucose is controlled by two hormones, insulin and glucagon. Normal blood glucose level is about 110 milligram per deciliter. When the blood glucose level is increased, It will stimulate secretion of insulin from the pancreas. Insulin is produced. It will act on the liver and the tissues, muscle and other tissues, to enhance the glucose uptake. And it will stimulate the liver to convert glucose into glycogen which will be stored. These actions will result in lower glucose blood level. When the blood level reaches its level, the production of insulin is reduced. On the other hand, when the plasma glucose level is decreased, stimulate the pancreas to secrete glucagon, which will act on the liver to stimulate glucose production through conversion of glycogen to glucose. This will normalize blood level to normal. So mainly blood glucose level is controlled by two hormones, insulin and glucagon. The difference between type 1 diabetes and type 2 diabetes. In type 1 diabetes, there is insufficient insulin produced by beta cells, so insulin is not available to act and remove glucose from the blood to the tissues. So there is defect in the action of insulin. In type 2 diabetes, there is insulin produced, which may be insufficient, or there is insulin resistant to open the glucose transporter and remove the glucose from the body into the tissues. Type 3 diabetes mellitus is diabetes due to multiple other specific causes, genetic disorders, infections, which include genetic disorders, infections, disease of the pancreas, endocrine pathologies, non-pancreatic disease, drug therapy. So this type of diabetes is caused by other Type 4 diabetes mellitus is known as gestational diabetes, which is occur during pregnancy or seen first time during pregnancy. During pregnancy, placenta and placental hormones create an insulin resistance that occur mostly in the last trimester. Gestational diabetes, there is high blood glucose level in the mother, which will put extra weight for the baby, causes the baby to put on extra weight. This slide shows the 4 types of diabetes. Type 1 diabetes usually occurs in people before 30 years of age, young people, characterized by destruction of the beta cells that secrete insulin, so treated mainly with insulin. In this type of type 1 diabetes, there is destruction of the beta cells by autoreactive T cells, which attack islet cells and destroy them. So there is no insulin secreted during in type 1 diabetes. Type 2 diabetes, blood glucose level rise due to lack of insulin production, or insufficient insulin action. That's insulin resistance. Commonly detected in people after 40 years of age. At the end, the disease will progress in that the insulin is not produced from the cells, and resulting in insulin dependence. In late stages of type 2 diabetes, the ability to secrete insulin by beta cells is lost, and the patient requires insulin replacement therapy. Type 3 diabetes, as we said, there is multiple factors that may cause an elevation in blood glucose level. Type 4 diabetes is associated with pregnancy and associated with pregnant due to hormonal changes. Management of diabetes mellitus has three major components, which is first, diet and exercise; second, insulin therapy; third, oral hypoglycemic agent. Diet, first, diet and exercise. Diet is a basic part of management in every case. Should be started with diet control. Dietary treatment should aim at ensuring weight control. That is, give him a good diet to ensure his weight control in obese people. Providing a nutritional requirement for the patient, allowing good glycemic control with blood glucose level as close to normal as possible, correcting any associated blood level abnormalities. Recommended dietary guidelines for type 2 diabetes. The diabetic patient should reduce his total caloric intake per day. In most cases, the diet should be high in carbohydrate with low fat and low cholesterol content in the diet. A dietary fat should provide about 25 to 35% of calories. Protein intake should provide 10 to 15% total energy. Carbohydrates should be provide 50 to 60% of total calorie, and the carbohydrates should be complex and high in fiber. Also, you should reduce fat intake to less than 30% of calories. Cholesterol level should be less than or equal to 300 milligram daily. The patient can use artificial sweeteners such as aspartame and saccharin, safe, and they are used by people with diabetes. Nutritive sweeteners such as fructose and sorbitol, their use is increasing, except excessive intake of sorbitol can cause osmotic diarrhea, and excessive intake of fructose can increase the total and low density lipoprotein cholesterol. The patient should avoid excessive salt in his diet and avoid alcohol drinking and smoking. The exercise. Adequate exercise or physical activity level would lead to weight reduction and has been found to cause weight reduction and improve insulin sensitivity. Therefore, they may lower plasma glucose level. Physical exercise and dietary treatment program can reduce the blood glucose level alone and should be considered for each patient. Pharmacological therapy. We have two types of therapy: insulin treatment, usually given for type 1 diabetes and in the late stages of type 2 diabetes. Oral hypoglycemic drugs or agents, they are used for treatment of type 2 diabetes. Pharmacological therapy of type 1 diabetes. Choice of therapy is simple. All patients need insulin. As we said before, type 1 diabetes, there is no insulin secreted from beta cells due to their destruction. Insulin is a small protein with a molecular weight of about 5,800. It contains 51 amino acids arranged in two chains, chain A and chain B, linked by disulfide bond. Usually synthesized and stored as proinsulin. Proinsulin is hydrolyzed into insulin and peptide C. Insulin secretion. Insulin is released from pancreatic cells in the pancreas, usually at a low basal rate during the day and at much higher concentrations in response to diet or other variety stimuli. The stimuli that cause insulin secretion include glucose, amino acids, hormones, high concentration of fatty acids, beta-adrenergic sympathetic activity, and some drugs, which will increase the insulin secretion and used in treatment of type 2 diabetes. Mechanism of insulin release. Increase in the plasma level of glucose leads to increase in the intracellular ATP level. With the closure of ATP dependent potassium channels, decrease in potassium efflux, which will lead to depolarization of beta cells and the opening of calcium channels. This will result in increase in intracellular calcium with the release of insulin. Degradation. Insulin degradation. Insulin is destroyed or metabolized in the liver and kidney by the hydrolysis of the disulfide bonds which connect the two chains of insulin A and B. In insulin-treated diabetic, kidney remove about 60%, while the liver 30 to 40%. The half-life of circulating insulin is about 3 to 5 minutes. Insulin receptor. Insulin acts on a specific receptor found on the membranes of most tissues, including liver, muscle, and adipose tissue. The insulin receptor is a transmembrane glycoprotein composed of 4 units, 2 alpha units and 2 beta units. Insulin binds to the alpha unit, which is known as recognition site. This binding of insulin to alpha subunits leads to activation of tyrosine kinase domain on the beta cells, which will lead to phosphorylation of tyrosine residues at cytoplasmic protein. Phosphorylation will result in translocation of glucose transporter from the cell into the cell membrane with the following action. It will increase glucose uptake into the tissues such as muscle and fat tissue. It also will stimulate glycogen synthase activity in order to store the excess glucose as glycogen. Multiple effects on protein synthesis, lipolysis, and lipogenesis, activation of transcription factors that enhance DNA synthesis, and cell growth and division. This slide shows the mechanism of insulin. Insulin, we said the receptor has two subunits, alpha unit, which is known as recognition site, found on the cell membrane, and beta, two beta units inside the cell. So the interaction of insulin with its receptor leads to transduction of the signal transduction with the activation of phosphorylation cascade with then we will see the biological response. This will lead to the translocation of glucose transporters from the cell into the cell surface with the uptake of glucose into skeletal muscle and adipose tissue. Effect of insulin on its targets. As we said that there is insulin or glucose transporters that should transport glucose from the blood into the different type of tissues. Glucose these transporters include 1, 2, 3, 4, and 5. The most important one is glucose transporter 4, which is found on muscle and adipose tissue, and it mediates insulin uptake from the blood into these tissues. Effect of insulin. Insulin has effects on many organs, including first the liver, where it produces anabolic action, promoting glucose storage and promote glucose storage as glycogen. It also increases triglyceride synthesis and very low density lipoprotein formation. On the muscle, insulin increases protein synthesis through increased amino acid transport and also increases ribosomal protein synthesis. In the muscle also it increases the glycogen synthesis, increases transport of glucose into the muscle tissues, induces glycogen synthesis to store glucose as glycogen. On adipose tissue, insulin usually increases triglyceride storage and induce and activate lipoprotein lipase to hydrolyze triglycerides from lipoproteins. Intracellular lipase is inhibited by insulin. Effects of insulin on target cells, as we said before, it stimulates skeletal muscle fibers, increases amino acid uptake, and stimulates protein synthesis. In liver cells, it stimulates glucose uptake to be stored as glycogen and fat, or stored as glycogen in the liver or as fat in the adipose tissue. On fat cells, it will stimulate the storage of glucose and change it into triglycerides stored in fat tissues. Inhibits the production of certain enzymes that will break glycogen. It inhibits the production of certain enzymes, such as enzymes that will break glycogen. Source of insulin. Insulin can be taken from pork insulin, but this This is the nearest insulin to the human insulin. There is only one amino acid difference between them. Beef insulin differs by 3 amino acids from a human insulin and may be antigenic. A human insulin produced by recombinant DNA techniques, less expensive and less immunogenic. Strength of the insulin usually given as units per milli, 100 units. Currently, all insulins are available in concentration of 100 unit per milli. 500 units are also available but used in some setting and in cases of insulin resistance. So we have 3 types of insulin, pork, beef, or human. Nowadays, most the insulin available is derived from a human source produced by DNA techniques. Insulin preparation. Insulin for clinical treatment. Insulin is formulated as soluble crystalline insulin, which is absorbed rapidly from subcutaneous site. Sometimes the insulin may be aggregated or complex with protein. This is done to slow the absorption and prolong its duration of action. The later, these preparations are only used for subcutaneous insulin preparations. 4 types of insulin preparations are available. First, rapid acting. These preparations differ in their onset and duration of action. Rapid acting insulin, they act rapidly within 15 minutes and has a short duration of 3 to 5 hours. Short-acting insulins also have rapid onset, but it's more than the first group. Onset is about 30 to 60 minutes and short duration of action of 5 to 8 hours. Intermediate acting insulins, they have a slow onset of 1 to 3 hours and duration of 12 to 16 hours. Long-acting insulins, they have a slow onset and long duration of action. Pre-mixed insulins, that's combination of two different types of insulin together. The first group, rapid-acting insulins. These include insulin Lispro, Aspart, and glulisine insulin. Usually, these insulins are clear solutions at neutral pH and contain small amount of zinc to improve stability and shelf life of the insulin. Given subcutaneously, they have a rapid onset in about 5 to 15 minutes and a duration of action of 3 to 5 hours. The shorter duration of action will decrease the risk of post-meal hypoglycemia. Can be taken immediately before the meal. They also have lowest variability of absorption, about 5% among all the other formulation of insulin. Short-acting insulins, a second group, contains example regular, soluble, or crystalline insulin. All the same name, regular insulin, soluble, or crystalline insulin. Onset is within 30 to 60 minutes, peak in 2 to 4 hours, and a duration of action of 5 to 8 hours. Being clear solution, they can be administered intravenously in cases of emergency. Useful for intravenous therapy in the management of diabetic ketoacidosis, gestational diabetes, surgery, or during acute infection when insulin requirement is changing rapidly. So they can be given intravenously in some acute or some emergencies of diabetes. Duration of action, but they have delayed onset of 1 to 3 hours and long duration of 12 to 16 hours. Delayed absorption and this delay in absorption and onset is due to combining insulin with protamine, usually used with regular aspart or glulisine short-acting insulin in order to compensate for the for the delayed onset of intermediate insulins. This group will not act until 1 to 3 hours, and insulin Lespro or aspart act within 5 to 15 minutes and lasts for about 4 hours. So they will work before these intermediate insulins cover the period before that the intermediate insulin will act. Long-acting insulins, these include insulin glargine, which is a soluble and peakless insulin, usually provide reproducible and convenient basal insulin replacement. That it has a long duration of action, giving a steady concentration of insulin during the day. This type of insulin precipitate after subcutaneous injection to form a microcrystals that slowly release insulin, giving the basal insulin, giving a level similar to the basal insulin secreted in the body normally. They have slow onset, about 1 to 1.5 hours, with longer duration, near 24 hours. Usually given once daily. The formulation, this insulin formulation is usually acidic to maintain solubility, and therefore insulin glargine should not be mixed with other insulins or intravenous fluid. Being long-acting, it will reduce the risk of hypoglycemia or natural hypoglycemia during the day and during the night. Insulin and long-acting insulin is insulin digludec, which is known commercially as Tripoli. It's a ultra long-acting insulin. Work by slowing down the rate at which bloodstream absorbs insulin molecules. Being long-acting, it's taken as one daily dose. One advantage of the long duration of Tripoli is that it offers more flexibility in terms of injection timing. Works better than older version of long-acting insulin, but it's more expensive. The third type in long-acting insulin is insulin detemir or levemir, known commercially as levemir. This type of insulin is characterized by less weight gain and reduced risk of hypoglycemia than MBH intermediate insulin. Dose-dependent onset of about 1 to 2 hours and duration of action of more than 18 to 24 hours, given once or twice daily. Fourth type of long-acting insulin is ultra-length insulin, or which is insulin zinc suspension. This type of insulin is an amorphous precipitate of insulin and zinc. It provides a combination of relatively rapid absorption, 1 ila 2 hours onset, and long duration of action of more than 20 hours. This slide shows the different type of insulins, rapid, short, intermediate, and long-acting insulin, the preparation available from each type, duration of action, and time or some features, characters for each group, and the route of administration. Say rapid-acting insulin, such as aspartate lisproglolisine, duration of action is about 3 hours, can be given 15 minutes before meals, and provides postprandial insulin to compensate for hyperglycemia following diet. Preferred for use in subcutaneous and insulin infusion. They can be given also in insulin infusions. Short acting, which is known as regular insulin, duration of action is about 6 hours, can be given 30 minutes before the meals. Provide also postprandial insulin to compensate for the hyperglycemia produced after eating. Usually given subcutaneous, can be given intravenously in cases of emergency such as diabetic ketoacidosis. Intermediate acting MBH, duration of action is about 15 hours, provide basal insulin given subcutaneous. Long acting, as we said, glargine detemir, duration of action is about 24 to 30 hours, provides basal insulin and given subcutaneously. Pre-mixed preparations tend to be unstable. Therefore, advise the patient to mix them immediately before injection in the same syringe. And the other, control blood sugar between the meals during the day. Examples: 70-30% MBH and regular insulin, known commercially as Humulin. MBH will not act until about delayed onset, about 1 to 5 hours. Regular insulin act within 30 minutes, so it will provide and has a duration of about 6 hours or 8 hours. It will compensate for the delayed action of MBH insulin. Neutral protamine lespro combination between neutral protamine insulin and lespro. A neutral protamine aspartate also available. These are more stable and have the same duration as MBH insulin. 75% for 25% mixture of NBL and اللي هو neutral protamine lespro and neutral protamine aspart 70 to 30%. They also provide rapid onset, about 30 minutes, and long duration reaching up to 24 hours. Insulin, glargine, and detemir must be given as a separate induction. Being acidic in nature, they should not be mixed with other insulins, as they are not miscible with other insulins, and with any other, as they are not miscible with any other insulin preparation. So if you decide to use glargine or detemir from the long-action insulin and with rapid-acting insulin or short-acting insulin, you should give them separately, each one in a different syringe. This slide shows the available preparation of insulin, which is rapid acting, intermediate acting, and long acting, and then the pre-mixed human and pre-mixed analog preparation of insulin. We can see the onset of these preparations, the peak level, and the duration of action. Afreeza is a type of insulin that can be taken by inhalation. Inhaled insulin is rapid acting if it's approved by the Food and Drug Agency in the USA for use before meals for both type 1 and type 2 diabetes. It has a peak plasma level will occur within 15 ila 20 minutes, and a duration of action is about 2 to 3 hours. It must be used along with long-acting insulin in people with type 1 diabetes. Insulin delivery systems, that's how we give insulin to the patient. Standard delivery using a needle and syringe. The individual will draw the dose of insulin from the vial using a syringe and inject it subcutaneously by subcutaneous injection. Portable bin injections. These are ready bin-like devices. They are used to facilitate multiple subcutaneous injection when the patient needs more than one injection per day. The bin can be loaded with a cartridge containing insulin and set bin to deliver the pre-measured uses of insulin. Insulin is applied mainly or used for insulin-dependent diabetes mellitus or type 1 diabetes. It can also be used in non-insulin dependent diabetes mellitus when hyperglycemia is not controlled by oral anti-diabetic drugs. Usually it's used in type 2 diabetes in the late stages. Diabetes mellitus with stress, such as in cases of surgery, infection, or myocardial infarction. Diabetes mellitus with severe liver and renal disease. Treatment of diabetic ketoacidosis. Diabetic ketoacidosis or DKA is usually associated with type 1 diabetes. Symptoms include nausea, vomiting, abdominal pain, deep, slow breathing, change in mental status, elevated blood and urinary ketones and glucose. Arterial blood pH is less than 7.3 and low bicarbonate level less than 15 millimole per liter. Treatment of this case should include it needs aggressive intravenous hydration, insulin also given intravenously, usually regular insulin or soluble insulin. Maintenance of electrolytes, especially potassium and other electrolyte level in the body. 6 use of insulin is in treatment of hyperosmolar hyperglycemic syndrome, which is associated with type 2 diabetes characterized by profound hyperglycemia and dehydration. Usually caused by inadequate hydration, especially in the elderly, that result in or the use of drugs that elevate the blood glucose level, such as phenytoin, steroids, diuretic, beta blocker, and hemodialysis. Symptoms: declining mental status, seizures, plasma glucose over 600 milligram per deciliter. A treatment usually aggressive start with rehydration, restoration of glucose and electrolyte, and low dose of insulin therapy may be complications or adverse effect of insulin therapy. The most common is hypoglycemia, which can be caused by delayed intake of the meal or inadequate carbohydrate intake, unusual physical exertion, or high dose of insulin. Hypoglycemia will lead to stimulation of the signs of autonomic hyperactivity. In the sympathetic side effects will include tachycardia, palpitation, and sweating. Parasympathetic will include nausea, hunger, and weight gain. Convulsions and coma if untreated. Treatment of hypoglycemia if developed due to insulin therapy. First, glucose about 10 to 15 gram given orally if the patient is conscious. 20 to 50 milli of 50% glucose solution given by intravenous infusion if the patient is unconscious. 1 milligram of glucagon injected either subcutaneous or intramuscular. Second complication of insulin therapy is immunopathology of insulin therapy. Insulin may cause allergy, especially if the insulin is derived from not from human source but an animal source. It will lead to insulin allergy characterized by immediate type hypersensitivity, leading to characterized by urticaria and anaphylaxis due to the release of histamine. To avoid this side effect, usually it's advised to use highly purified human insulin, which is decrease the incidence of. The third adverse effect of insulin is lipodystrophy at the site of injection. This usually occurs with older animal insulin preparations that may lead to atrophy of subcutaneous fatty tissue at the site of injection. This side effect never seen with human insulin preparations. Treatment advised the patient to change the site of injection or use liposuction for treatment of this side effect. Used experimentally to produce diabetes in experimental animals. Phenytoin also causes increase in plasma level. All these drugs increase the plasma concentration of glucose. So during treatment with any of these drugs, you should monitor the plasma glucose level. Oral antidiabetic drugs. These are mainly used for treatment of type. Currently, there is 8 classes of antidiabetic drugs used. First class is insulin secretogens. That's a drug that stimulates insulin secretion from insulin secretion from the beta cells in the pancreas. These include sulfonylurea, meglitinides, diphenylalanine derivative. Second group, biguanides. Third, thiazolidinediones, alpha glucosidase inhibitors, bile acid sequesters, amylin analog, glucagon-like peptide 1 receptor agonist, dipeptidyl peptidase 4 inhibitors. The action of anti-diabetic drugs, they act at different organs. They may act on the pancreas to stimulate insulin secretion, such as sulfonylurea. They may act on the liver to decrease hepatic glucose production, such as metformin or biguanides. They may act on the gastrointestinal tract to decrease the absorption of glucose or decrease GIT motility. Also, they may act on adipose tissue or skeletal muscle to increase الانسولين sensitivity زي الثايوغليتازون أو thiazolidine On the kidney, this group of drugs may increase the excretion of glucose by the kidney. We will start with the first group, insulin secretogenes. These include, as we said before, sulfonylurea, meglitinides, and diphenylaniline derivative. First, urea. Mechanism of action, they act by stimulating the insulin release from pancreatic beta cells, which is the main mechanism of action for sulfonylurea. This will result in reduction of hepatic glucose production. Reduction of serum glucagon. Other mechanisms include reduction of serum glucagon and increase in insulin receptor sensitivity. The mechanism of action, how sulfonylureas stimulate insulin release from beta cells. Sulfonylureas usually bind to a specific receptor for them that's associated with the beta cell inward rectifier ATP sensitive potassium channel. Binding to the receptor block ATP dependent potassium channel, leading to decrease in potassium efflux from the cell that result in beta cell depolarization, opening of the voltage gated calcium channel with the influx of calcium into the cell, which will stimulate the secretion of pancreas. Other mechanisms include decrease in glucagon release and increase in insulin receptor sensitivity. For sulfonylurea, in order to be acting, at least about 30% of beta cells in the pancreas should be active. And second mechanism is the reduction of serum glucagon concentration. This results from the increase of insulin secretion caused by these drugs, lead to decrease in the serum glucagon level and hypoglycemic effect. The mechanism is unclear, but appears to involve indirect inhibition due to enhanced release of insulin and somatostatin from alpha, which inhibit alpha cell secretion. Classification of sulfonylurea. Sulfonylurea classified into 3 generations. First generation, which is old, the first drug produced, and they are rarely used nowadays: tolbutamide, chlorbromamide, and tolazamide. Second generation, glubride, glipizide, and glimbride. More commonly used of sulfonylureas, as they are more potent than the first group, and they have fewer side effects and drug interaction compared with the first generation sulfonylurea. Pharmacokinetics, given orally, sulfonylurea given orally, they have a high plasma protein binding, about 90%, metabolized in the liver, eliminated by the kidney and the liver. Tolbutamide has the shortest duration of action among the sulfonylurea, while the second generation has a long duration of action of about 24 hours. These are, this table show the generation of the different generation of sulfonylurea, their doses, duration of action, and if they are metabolized to active metabolite or not. First generation, tolbutamide, chlorbromamide, tolazimide, all usually used in high doses compared to the second and third generation. Say for tolbutamide, 1 to 1.5 gram daily, compared to about 10 milligrams of glipizide from the second generation. Duration of action, tolbutamide has the shortest duration of action among these drugs, about 6 to 12 hours, metabolized to an active metabolite. Second generation chlorbromamide has a very long duration of action, about 24 to 60 hours, which will increase the risk of hypoglycemia during sleep. So it's not recommended nowadays for use. Second generation are more used, second and third, more used than the first generation because they are more potent, using smaller doses compared to the first generation. Long acting can be given as one daily dose. Most are not metabolized to active metabolites, except for glimepiride, which is metabolized to active metabolite. First generation sulfonylurea, as we said before, tolbutamide is the most common drug used in this group. It has a short half-life of about 4 to 5 hours. It's safe, recommended for use in elderly because it's safe, and due to its short duration of action, it will not produce hypoglycemia during night. Given orally, converted in the liver to weak active metabolite, hydroxytolbutamide, and then it will be carboxylated to inactive compound and excreted by the kidney. Chlorbromamide has a long half-life of about 32 hours, produce prolonged hypoglycemia, which is more common in elderly, so it's contraindicated in elderly. Adverse effect of first generation sulfonylurea include hypoglycemia, rare with drugs that inhibit metabolism, but may mostly occur, very rare due to short action, except with drugs that may stimulate the metabolism of tolbutamide, زي dicumarol, phenylbutazone, and some sulfonamides. Prolonged hypoglycemia are common to occur with chlorbromamide, contraindicated in liver and renal failure, as they metabolize in the liver and excrete the kidney. Second generation sulfonylurea include glimepiride, glipizide, or glimepiride. More frequently used than the first generation because they are more potent, using smaller doses, and have fewer side effect and drug-drug interaction. Glimepiride, it has a duration of action of 10 to 24 hours. The drug usually metabolized in the liver into products with very low hypoglycemic activity. Glimepiride has a minimal transfer cross placenta and may be safe alternative to insulin therapy in diabetes and pregnancy. Adverse effects, it will cause hypoglycemia, flushing, rarely reported after ethanol ingestion. Slightly enhances free water clearance. The drug is contraindicated in presence of hepatic and renal insufficiency. Glipizide, it has a duration of action of 10 to 4 hours. It's recommended to take the drug 30 minutes before breakfast, as its absorption is delayed when taken with food. 90% of the drug is metabolized in the liver to inactive product, which is excreted in urine. 10% of the drug is excreted in the urine without metabolism. Adverse reactions, the same, and these drugs will cause hypoglycemia, but it's less than with that occurring with the glubride. Contraindicated the patient with significant hepatic and renal impairment. Glimbride, it has a long duration of action, and it's the most potent drug in this group, approved for one daily monotherapy or in combined therapy. Potent, achieves blood glucose level with the lowest dose, about 1 to 8 milligram of any sulfonylurea. Has a long duration of action reaching up to 24 hours, allowing for one daily dose. Therefore, it will improve the patient compliance. Completely metabolized in the liver to inactive. Adverse effect of sulfonylurea in general, they will cause hypoglycemia, hyponatremia, usually with tolbutamide and chlorprobamide. Potentiate the action of this will due to the potentiation for the action of antidiuretic hormone. This group of drugs will cause weight gain, flushing, disulfiram-like syndrome, which will be more severe with chlorprobamide. Drug interactions, first displacement from protein binding site. These drugs can be displaced from their plasma protein binding site by drugs such as warfarin, salicylate, phenylbutazone, and sulfonamide. So they may lead to hypoglycemia. Alters the hepatic. Also, there is interaction with drugs that affect the hepatic metabolizing enzymes or cytochrome B450. Chlor drugs that may be affected include chloramphenicol, MAO inhibitors, cimetidine, and rifampicin. All these drugs will cause inhibition in the activity of hepatic metabolizing enzymes, except rifampicin, which is an enzyme inducer. Altered renal excretion, such as allopurinol and allopurinol, which is the drug used for both allopurinol and propanol, drugs used for treatment of gout. They may affect the renal excretion of these. Second group in the insulin secretagogues include meglitinides, such as ribaglinide. These drugs developed in 1989. They tend to stimulate the insulin secretion from pancreatic beta cells by causing the closure of ATP potassium channels and the opening of calcium channel with the release of insulin. It has the same mechanism as sulfonylurea. Usually used to control postprandial glucose exertions, the increase in glucose following eating. Because they have very fast onset with the peak effect in 1 hour and short duration of action of about 4 to 7 hours. Administered before meals, about 30 minutes before meal, right up to the meal time. It can be taken before the meals, either 30 minutes or any time before taking the meal. Ribaglinide is used for treatment of type 2 diabetes as immunotherapy or in combination with metformin. It's given orally, rapidly metabolized by liver enzyme cytochrome B3A4 and excreted through the bile. Contraindication, the drug is contraindicated in patient taking gemfibrozole, clarithromycin, etraquilozole, ketoconazole, MAO inhibitors because of the risk of developing severe prolonged hypoglycemia. Because all these drugs will inhibit the activity of the enzyme that metabolize ribaglinide. Used in caution with in patient with. The third group is diphenylalanine. The third group is diphenylalanine derivatives, which include natiglinide. Natiglinide act by the same mechanism as with sulfonylurea. They cause very rapid and transient release of insulin from beta cells through closure of ATP sensitive potassium channel. The insulin release is glucose dependent and is decreased at low blood glucose level. Natiglinide amplifies the insulin secretion or secretory response to glucose load, but it has a diminished effect on the presence of normoglycemia. This means that natiglinide will increase the insulin response when the blood plasma glucose level is high, but it will not stimulate the insulin release when the plasma blood glucose is natiglinide partially restores the initial insulin release in response to intravenous glucose tolerance test. Useful in type 2 diabetes associated with the loss of initial insulin response. It also results in restoration of more normal insulin secretion, may suppress glucagon release in early meal and result in endogenous or hepatic glucose production. Useful in some patients with isolated postprandial glycemia given before the meals. The drug is effective when used alone or in combination with natiglinide. Is given orally, absorbed within 20 minutes, and metabolized in the liver by cytochrome B2C9 and cytochrome B3A4 enzymes with a half-life of 1 hour and duration of action of 4 hours. Has the lowest incidence of hypoglycemia in this group, safe in individuals with very reduced renal function because the drug is metabolized in the second group of drugs used for treatment of type 2 diabetes is biguanide. We have one drug in it, metformin. The primary mechanism of action of this drug is to reduce hepatic glucose production through the activation of enzyme A and B activated protein kinase. It also increases peripheral glucose utilization by skeletal, especially in skeletal muscle. Other minor mechanisms of action include direct stimulation of glycolysis in tissues and the use of glucose, slowing of glucose absorption from gastrointestinal tract with increased glucose conversion glucose to lactate. Impairment of renal gluconeogenesis, reduction of plasma glucagon level. But the main mechanism is primarily to reduce hepatic glucose production from the liver. Metformin is termed as euglycemic agent. This means treating the diabetic patient with metformin will have less fasting hyperglycemia, and lower postprandial hyperglycemia. Metformin does not cause hypoglycemia, so there is no hyperglycemia with metformin therapy. It has a half-life of 1.5 to 3 hours, not bound to plasma proteins, and excreted by the kidneys as the active drug. Block metformin lead to blockade of gluconeogenesis, that's the synthesis of glucose in the liver, leading to impairment of hepatic metabolism of lactic acid. In patients of renal insufficiency, metformin may accumulate and increase the risk of lactic acidosis. The uses of metformin. Metformin is used as a first-line therapy in treatment of type 2 diabetes because it's an insulin-sparing agent, does not affect the insulin secretion, does not increase the weight of the patient, does not cause hypoglycemia. Metformin has also been found to decrease the risk of macrovascular and microvascular disease. Can be used alone or in combination with insulin, with insulin secretogenes drugs such as sulfonylurea or thiazolidinediones in type 4, type 2 diabetes. Metformin has been found, several studies reported that metformin was able to prevent the development of type 2 diabetes in middle-aged obese persons with impaired glucose tolerance and fasting hyperglycemia. Side effects or adverse effects of metformin, mostly GIT side effects occurring in 20% of the patient and are dose dependent. These include nausea, anorexia, vomiting, abdominal discomfort, and diarrhea. Metformin may decrease the absorption of vitamin B12 with long-term therapy. Biguanides or metformin is contraindicated in patients with renal insufficiency, congestive heart failure, alcoholism, or hepatic disease. Or any other conditions that lead to tissue anoxia because it may increase the risk of lactic acidosis induced by metformin. Insulin secretogenes, first group, second group biguanides, third group used for treatment of type 2 diabetes is thiazolidinediones. Or thiazolidine ions can be also known as glitazones, include bioglitazone or rosiglitazone. Their mechanism of action, they act as peroxisome profilator activated receptor gamma agonist. They are insulin synthesizers and act to decrease resistance, insulin resistance in periphery, or increase sensitivity of muscle, fat, and liver to the action of insulin. Thiazolidinediones mechanism of action, they bind to and activate peroxisome proliferator activated receptor, which is a nuclear receptor. This receptor will modulate the expression of genes involved in lipid and glucose metabolism, insulin signal transduction, differentiation of adipocytes and other tissues. Modulation of these genes will and modulation of the expression of these genes will lead to an increase in insulin sensitivity in adipose tissue, liver, and skeletal muscle, with more glucose uptake and utilization. decrease the level of triglycerides, and increase the level of high-density lipoprotein. In patients with diabetes, the major site for thiazolidine action is in adipose tissue, increasing glucose uptake and utilization, modulate the synthesis of lipid hormones, cytokines, and other proteins involved in energy regulation, regulate adipocyte apoptosis and differentiation, decrease triglycerides, and enhance high-density lipoprotein in adipose. The first drug, البيوجليتازون, given orally, absorbed after oral administration, metabolized by hepatic enzymes cytochrome B2C8 and cytochrome B3A4 to active metabolites. The majority of the drug and the metabolite excreted in bile and eliminated in feces. The triglycerides lowering level is more significant than that absorbed with the other drug in this group, اللي هو rizoglitazone. Taken once daily, beclitazone is approved. Bioglitazone is approved used as immunotherapy and in combination with metformin, sulfonylurea for treatment of type 2 diabetes. The second drug in this group is rosiglitazone, given orally, rapidly absorbed with high plasma protein binding effect, metabolized in the liver by liver metabolizing enzymes. Metabolites are primarily excreted in urine. Given once daily, the drug is approved for use in type 2 diabetes as immunotherapy or combination with biguanides or sulfonylurea. It has no significant drug. Thiazolidine ions, also known as euglycemic agents, that is, decreasing plasma glucose level when it's high but does not affect the normal plasma glucose level. They have been found to be effective in about 70% of new users. Response is similar to that produced by sulfonylurea or metformin monotherapy. They can be used or added to other drugs when there is failure in treatment with other oral agents. Thiazolidine diones has a slow onset and offset activity, which takes about weeks or even months, because the mechanism of action of these drugs include gene regulation and transcription of proteins. These drugs does not cause, normally they don't cause hypoglycemia, but hypoglycemia may occur when they are combined with other drugs such as or insulin therapy. Adverse effects: hypoglycemia, not alone, but when used in combination, they may cause hypoglycemia. Fluid retention, mild anemia and peripheral edema with insulin or insulin secretogens, increase the risk of heart failure due to fluid retention. Dose-related weight gain, they also cause weight gain, average of 1 to 3 kilogram, which may be related to fluid retention. Demineralization and increased fracture in women due to their effect on decreasing the osteoblast formation in the bone. Long-term therapy may be associated with decrease in triglyceride level and slight increase in high-density lipoproteins and low-density lipoprotein cholesterol values. Contraindications of thiazolidinediones include pregnancy, significant liver disease, as these drugs are mainly metabolized by hepatic enzymes, heart failure as they cause fluid retention, and an ovulatory woman. Troglitazone is withdrawn from the market because of its hepatotoxic effects. Regular monitoring, الFDA or the Food and Drug Administration Agency require regular monitoring of liver function tests for the first year after initiation thiazolidinediones. To date, hepatotoxicity has not associated with the use of rosiglitazone or bioglitazone. The fourth group that used for treatment of diabetes is alpha-glucosidase inhibitors. Alpha-glucosidase inhibitors include two drugs, acarbose and megitol. These drugs competitively inhibit the intestinal alpha-glucosidases and reduce the postprandial digestion and absorption of carbohydrate such as starch and disaccharides. They target alpha-glucosidases such as saccharose, maltose, glycoamylase, and dextranase. The consequences of enzyme inhibition consequence of alpha-glucosidase inhibition is minimize the upper intestinal digestion and prevent digestion and absorption of ingested starch and disaccharides in the distal small intestine. The net effect is to reduce the postprandial blood glucose level by 45 to 60 milligram per deciliter and creating an insulin-sparing effect. So these drugs, by reducing the absorption and digestion of carbohydrate in the GIT, they reduce postprandial glucose rise by 45 to 60 milligram per deciliter and therefore reduce the need for insulin. As monotherapy, they tend to decrease 0.5 to 1% of HbA1c plus 20 to 25 milligram decrease in fasting glucose level. These drugs are taken at the beginning of meals. They can be used as a monotherapy or in combination therapy with sulfonylurea, where they give or produce additive effect. In pre-diabetics, that's the patient who at risk to develop diabetes, alpha-glucosidase therapy has been found to prevent the development of diabetes, type 2 diabetes in the population and help to restore beta cell function to produce insulin. Side effects, mostly flatulence, diarrhea, and abdominal pain, result from the appearance of undigested carbohydrate in the colon. These carbohydrates will be fermented into short chain fatty acids, releasing gas, leading to flatulence. Hypoglycemia, only when combined with sulfonylurea, treated with glucose, not dextrose and not saccharose, whose breakdown may be blocked by alpha-glucosidases. Contraindication, they are usually contraindicated in inflammatory bowel diseases or any intestinal conditions that could be worsened by the gas and distension. Renal impairment, both drugs are excreted by the kidney. Acarbose may cause reversal hepatic enzyme elevation and should be used with caution in patients with hepatic. The fifth group is bile acid. The fifth group is bile acid sequestrants. One drug is present in this group, colcivilam, which is used first as a bile acid sequestrant and cholesterol lowering agent. Approved for treatment of type 2 diabetes, not controlled by diet, exercise, and other medications. The mechanism of action is unknown but may include interruption of enterohepatic circulation. Second, these drugs cause decrease in farnesoid receptor X activation, which is a nuclear receptor with multiple effects on cholesterol, glucose, and bile acid metabolism. Bile acids are ligands of farnesoid receptor X. And binding of this bile acids will decrease the activation of this receptor. They also may impair glucose absorption from gastrointestinal. The drug is given orally, not absorbed and excreted intact in feces. Side effect, it may cause gastrointestinal local effect in the gastrointestinal tract, which include constipation, indigestion, and flatulence. May impair absorption of other drugs such as fat-soluble vitamins and globride anti-diabetic drug, L-thyroxine, and oral contraceptives. The sixth group is amylin analog. Amylin or isolate amyloid peptide. Amylin is a 37 amino acid peptide produced by bile pancreatic beta cells and present in the beta cell, stored in the beta cells. Its concentration is about 1 to 2% that of insulin, and it's secreted in response to beta cell secretogenes. Approximately one molecule of amylin is released for every 10 molecules of insulin. Physiological effect of amylin may be to modulate insulin release by acting as a negative feedback on insulin secretion. At pharmacological doses, amylin, it has been found to reduce glucagon secretion, slows the gastric emptying, and centrally decreases the appetite. Example of this group is bromelainide, which is analog of the amylin. Bromelainide is an synthetic amylin analog used to modulate the postprandial glucose level. Approved for pre-prandial use in type 1 and type 2 diabetes. It acts to suppress glucagon release, delay gastric emptying, and has a central nervous system effect to suppress appetite. Given subcutaneously immediately before eating, rapidly absorbed, and with a duration of action of about 150 minutes. Metabolism and excreted by the kidney. May be administered in addition to combined with insulin. Adverse effect: hypoglycemia, GIT disturbances such as nausea. Used for treatment of diabetes, type 2 diabetes, is glucagon-like polypeptide or GLP-1 receptor agonist. which include exenatide and liraglutide. Incretins are hormones produced by the gastrointestinal tract in response of incoming nutrients. They have important action that contribute to glucose homeostasis. Two hormones are involved: gastric inhibitory polypeptide and glucagon-like peptide 1. Glucagon-like peptide 1 secreted in response to the ingestion of nutrients by L cells in the gastrointestinal tract, primarily in the ileum and colon. It has a receptor in islet cells and in the central nervous system, so it exerts its action through acting specific receptors in the pancreas and in the central nervous system. The disadvantages of glucagon-like peptide 1 is that it's rapidly metabolized by the enzyme dipeptidyl peptidase 4. So, be brief. The actions of glucagon-like peptide 1, it enhances glucose-dependent insulin secretion, inhibits glucagon secretion and hepatic glucose production, slows gastric emptying, increase satiety resulting in less food intake, appears to stimulate insulin gene transcription leading to more insulin synthesis. In animal studies, it has been found to increase the beta cell mass by decreasing the beta cell apoptosis and stimulating the growth of new beta cells. Glucagon-like peptide 1 analog is exenatide. They act on both the pancreas and liver. They are secreted from L type cells found in the ileum and colon. They will secrete glucagon-like peptide 1. It will act in pancreas to decrease glucagon secretion and enhance glucose uptake by the liver and stimulate insulin secretion. Its action will be applied into the brain, where it reduces the appetite or control appetite. It also acts on pancreatic beta cells to stimulate the insulin production and enhance the growth of new beta cells. It also may act on different tissues to reduce the insulin resistance. Important point is that as glucose level approaches normal, glucagon-like peptide 1 effects on insulin stimulation and glucagon inhibition decreases. So its effect is glucose dependent effect. So it will not produce hypoglycemia, which is a therapeutic advantage. The problem with glucagon-like peptide 1 is that it's rapidly broken down by dipeptidyl peptidase 4 enzyme. So it has very short half-life and requires continuous IV infusion. A solution for this problem is that incretins mimics are glucagon-like peptide 1 agonists, that they are resistant to hydrolysis by the enzyme. This is the first solution. Second solution is the use of dipeptidyl peptidase 4 inhibitors, which will inhibit the breakdown of glucagon-like peptide 1. This slide will show briefly what we said before, that glucagon-like peptide 1 is rapidly metabolized. Its action is to act on beta cells to stimulate release of insulin and to inhibit glucagon release, leading to lowering of plasma glucose level. But it's rapidly metabolized and its effect is brief. To solve this problem, we either use analogs of glucagon-like peptide 1, which are resistant to hydrolysis by dipeptidyl peptidase inhibitors, dipeptidyl enzyme, or use of drugs that inhibit the enzyme, such as sitagliptin. These two methods will preserve the action of glucagon-like peptide. The use of incretin mimetics, exenatide and liraglutide, both are synthetic analog of glucagon-like peptide 1, and they act as similar in a fashion similar to glucagon-like peptide activity. They bind to its receptor and act like glucagon like peptide 1 to potentiate the release, glucose-mediated release of insulin, increase the beta cell mass through decreasing apoptosis and increase the formation of new beta cells, suppression of postprandial glucagon release, slow of gastric emptying, and central loss of appetite. This slide shows the difference between the glucagon-like peptide 1 and the glucagon-like peptide 1 mimetics or drugs. Both will increase the glucose-dependent insulin secretion. Both will decrease the glucagon secretion and the hepatic output of glucose. Both will slow gastric emptying and therefore decrease the absorption of nutrients and glucose blood level. Both decrease food intake through their central action on the appetite center, decrease the plasma glucose acutely to near normal levels, resistant to dipeptidyl for degradation. Glucagon-like peptide 1 will be destroyed or hydrolyzed by this enzyme, while the mimetics will not be destroyed by this enzyme. They also differ in their duration in plasma following subcutaneous injection. Glucagon is rapidly metabolized, therefore it has a short duration, while mimetics are not affected by the enzyme and will have a long half. Exenatide is a naturally occurring peptide derived from the saliva of Gallia monster, as shown in the picture. It's resistant to inactivation by a dipeptidyl peptidase enzyme, given subcutaneously and absorbed following subcutaneous injection, with a half-life of about or duration of action of about 10 hours. Eliminated mainly by glomerular filtration, so dose adjustments should be done in a patient with creatinine clearance less than 30 ml per minute. Injected subcutaneously within 60 minutes before meal twice daily. Approved for use approved for type 2 diabetes with metformin and sulfonamide. Side effects: hypoglycemia only if combined with sulfonylurea and other hypoglycemic drugs. One of the groups that cause loss of weight, about 2 to 3 kilograms weight loss in some patients. They may cause nausea in 44% of users, vomiting, and diarrhea. Necrotizing and hemorrhagic pancreatitis, which may be rare but may be. Liraglutide is also glucagon-like peptide 1 analog, but it has a long half-life and can be used as one daily. The second group is dipeptidyl peptidase 4 inhibitors, or known as gliptins. Sitagliptin, saxagliptin, linagliptin, and vildagliptin. These drugs act to inhibit the enzyme dipeptidyl peptidase 4, which metabolize or degrade incretin hormones, which is glucagon-like peptide 1. So inhibition of this enzyme will result in increase in the endogenous concentration of glucagon-like peptide 1. So it will give you more response in decreasing postprandial glucose exertions by increasing the insulin secretion and decreasing the glucagon. Dipeptidyl peptidase 4 inhibitors are oral rather injectable drugs. They do not affect the body weight neutral, associated with low incidence of hypoglycemia or gastrointestinal side effect. Uses, they are indicated for type 2 diabetes as a monotherapy with diet and exercise, or in combination with metformin, sulfonylurea, thiazolidinediones, and insulin. Sitagliptin, or non-commercial as Genovia, has a oral availability of more than 85% and half-life was about 12 hours. 78% of the drug is secreted in urine by active tubular secretion. Can be used as a monotherapy or in combination with metformin, sulfonylurea, glitazones, and thiazolidinediones. Side effects: hypoglycemia with insulin secretogens or insulin, nasopharyngitis, headache, upper respiratory tract infections, acute pancreatitis, hypersensitivity reactions. If occurred, stop therapy with this drug. Gliptin is metabolized by cytochrome B3A4 and 5, two active metabolites, excreted both by renal and hepatic pathways. So, as a result, and dose should be adjusted in presence of renal impairment, and when the patient is taking drugs that inhibit the cytochrome B3A4 or 5, such as antifungal drugs and some antibacterial drugs. Side effects, there is include increased rate of infection in the upper respiratory tract and urinary tract, headaches, peripheral edema, especially if combined with thiazolidinediones, hypoglycemia when given with sulfonylurea, and hypersensitivity. Lingliptin, similar to sitagliptin and saxagliptin, approved as a monotherapy or in combination for treatment of type 2. New drugs developed for use of treatment of type 2 diabetes is known as glitaflozins or sodium glucose co-transporter 2 inhibitors, SGLT2 inhibitors. Sodium glucose linked transporter 2 or sodium glucose co-transporter 2 SGLT2 inhibitors are a new group of drugs used for treatment of diabetes, type 2 diabetes, and given orally. They they approved for use since 2013. They are taken once daily with or without food. These group of drugs act mainly on the kidneys to lower plasma glucose level. Anti-diabetic drugs in general, as we talked about before, include sulfonylurea, dipeptide peptidase inhibitor, glucose-like peptide 1 receptor agonist, biguanides, thiazolidiniols, and the last group is SGL2 inhibitors. They act mainly on the kidney, leading to inhibition of reabsorption of glucose from renal tubules. These include examples of this group is dapagliflozin, developed in 2012, first developed drug, canagliflozin, and emagliflozin, and others. Other new drugs developed recently. Mechanism of action. The kidney plays an important role in the regulation of carbohydrate metabolism. In normal physiological condition, glucose that filters through renal glomeruli is nearly totally reabsorbed in proximal renal tubule. Two transporters are engaged in this process. That's reabsorption of glucose. SGLT1 found in intestinal mucosa of small intestine and proximal straight tubule of the nephron, and it accounts for approximately 10% of glucose reabsorption at proximal straight tubule. Second transporter is SGLT2, found in proximal convoluted tubule of the nephron, and accounts for about 90% of the reabsorption of glucose. Their activity depends on sodium-potassium ATPase pump. Renal tubular glucose reabsorption is increased in type 2 diabetes, may lead to glucotoxicity. These drugs, administration of these drugs results in inhibition of renal tubular sodium glucose cotransporter and lowers the renal threshold for glucose. This will result in decrease in glucose reabsorption from renal tubule into the blood, increase in urinary excretion of glucose leading to glucosuria, decrease in plasma glucose, and reversal of glucotoxicity. The affinity of these drugs to SGLT2 transporter is approximately 150 times greater than that for SGLT1 transporter. These drugs blocks approximately 50 to 120 grams per day of glucose from being reabsorbed into the blood. This slide will show the mechanism of action of this group of drugs. Glucose, as glucose filters through glomeruli, it's usually reabsorbed. About 90% of the glucose filters is absorbed from the proximal tubule, S1 segment of proximal tubule, and the rest is reabsorbed from the distal S2, S3 segment of proximal tubule. The two transporters are responsible for this process, SGLT2 and SGLT1. So they will decrease glucose excretion in the renal tubule. These drugs will act mainly on SGL2 co-transporter, inhibiting reabsorption of glucose. About 90% of the glucose filtered will not be reabsorbed with the SGLT2 inhibitors lead to inhibition of SLT2 transporter at proximal convoluted tubule. Therefore, it will lead to prevention of reabsorption of glucose back into the blood and excretion of the glucose in the urine with the glucose-urea, and therefore result in reduction in how are SGLT2 inhibitors differ from other anti-hyperglycemic agents? These group of drugs are non-insulin dependent mechanism. They will not affect the insulin secretion or its action. They mainly can be used. So this group of drug inhibitors can be used in early or late type of diabetes, as they have no effect on insulin. Effect on weight. SGLT2 inhibitors, they cause glucose-urea, that's increase the excretion of glucose and preventing their reabsorption, leading to net calorie loss of approximately 200 to 300 calories per kilocalories per day, and this will result in weight loss. So use of this group will result in weight effect on blood pressure. They also have a beneficial effect on blood pressure. Producing glucose-urea. Glucose act as osmotic diuretic, leading to dehydration and reduction in blood pressure. First drug in this group is dapagliflozin. It's used for treatment of type 2 diabetes, used as immunotherapy or in combination therapy with metformin, glimepiride or insulin. It helps in producing weight reduction, helps to reduce the systolic blood pressure, less incidence of hypoglycemia, but it may controversy. Some studies have shown that they are associated with higher rate of bladder and breast cancer. On cardiovascular disease, this drug treatment showed a reduction of hospitalization of heart failure and reduction in the progressive chronic kidney disease. There is a recent label change for dapagliflozin, that's to include approved for use in chronic kidney disease down to glomerular filtration of 45 milli per minute. Previously it was more than 60 milli per minute. Second drug, empagliflozin, given orally, rapidly absorbed after oral administration, reaching the maximal plasma level within 1 to 3 hours. Also this drug, there is no risk of hypoglycemia, no hepatic impairment, no drug interaction with cardiovascular drugs like verapamil, ramipril, digoxin, and anticoagulant drugs such as warfarin. Reduction in the risk. It also produces reduction in the risk of cardiovascular therapeutic uses. These drugs are used for treatment of type 2 diabetes, and they act independently of beta cell function in the pancreas. They are equally effective as other anti-diabetic drugs, used as immunotherapy or combined therapy. Add on to, they can be used in combination with morphine, sulfonylurea, or thiazolidine ions. Can be used in combination therapy with dipeptyl peptidase 4 inhibitors or metformin. Can be added to insulin in type 2 diabetes, added to insulin in type 1 diabetes, in glucose intolerance test and glucose fasting glucose level. They reduce IC1, HbIC1 by more than 10%, added to glucagon like peptide 1 analogs. So they are, in brief, they are combined with, they can be used alone or combined with other oral anti-diabetic drugs, leading to about 10% decrease in HbAC1. Adverse effect, they tend to increase the incidence of genital and urinary tract infection, which is more in women than in men. This is because these drugs induce glucosuria and enhance urinary excretion of glucose. Urinary tract infection and female genital fungal may lead to urinary tract infection and female genital fungal infections. These include vaginal yeast infection, male genital mycotic infection, vulvovaginal candidiasis. They may cause increased urination during night, which may be tiring to the patient. The second side effect is hypoglycemia. Hypoglycemia is occurring in less than 5% of patients, but the risk of hypoglycemia may be increased when combined with insulin, sulfonylureas, or glinides. These drugs lack the effect on insulin secretion and glucose absorption in gastrointestinal tract. Hypotension, leading to dizziness and or fainting and decrease in renal function. Dehydration, intravascular volume, lead to intravascular volume depletion, dizziness or fainting on gastrointestinal tract. It causes thirst, constipation and nausea. Side effect, the other side effect is they cause hyperkalemia. Contraindication, they should not be used in diabetic ketoacidosis because it's an emergency case and needs treatment with IV drugs. Renal impairment, such as increased ketones in blood or urine, severe renal impairment, glomerular filtration less than 30 milli per minute. Also contraindicated in end-stage renal disease or patient on dialysis. Contraindicated in bladder cancer, especially dapagliflozin, which is reported to cause bladder cancer. Drug interactions, first with the drug-induced liver microsomal enzymes such as rifampicin, phenytoin, phenobarbital, retinovar. These drugs tend to increase hepatic activity of the enzymes and increase the metabolism of canagliflozin. So if the patient is taking these drugs, consider increasing its dose. May enhance the hypoglycemic effect of insulin and insulin secretory genes such as sulfonylureas. The effect of with diuretics, they may increase the effect of diuretics, therefore increase the risk of dehydration and hypotension. Cholestyramine may decrease canagliflozin absorption, therefore it should be given 1 hour before or 4 hours after cholestyramine. Advantages of SGL2 inhibitors. First, they have very high oral bioavailability. They have a long half-life, allowing for 1 daily dose. They reduce HB A1C level by 1%. They cause significant weight loss, about 5 to 10 pounds, due to loss of glucose load. They tend to reduce blood pressure approximately by 4% due to osmotic diuresis. Reduction of fat mass. They increase high density lipoprotein cholesterol and decrease triglycerides with low density lipoprotein cholesterol, with no change in the ratio of HLD to LDL cholesterol. They produce low risk of hypoglycemia. They maybe have a beneficial effect in type 2 diabetes, as they exert their effect in the kidney and not on the insulin. Disadvantages, they tend to have less effect in advanced renal failure or glomerular filtration less than 30 milli per minute. They have the risk of increasing urinary tract infections and genital infections. They may cause increased risk of dehydration, and they may cause electrolyte imbalance, as they may affect sodium, potassium, and calcium in SGLT2 inhibitors. They tend to improve glycemic control and the cardiovascular risk factors through their effect to corrects. This group has the advantages of being a new group, reduces HbA1 by 1%. They can be used in combination with other anti-diabetic drugs, giving a additive or synergistic effect. Reversal of glucotoxicity associated with type 2 diabetes and type 1 diabetes, as they increase glucose output. Less risk to produce hypoglycemia. They have the advantages of reducing blood pressure and increasing weight loss. And the main advantage is that these group of drugs correct a novel pathophysiological effect through increasing glucose loss, which is increased in cases of diabetes. Conclusions. SGLT2 inhibitors are new option in treatment of type 2 diabetes. They have insulin dependent mechanism which allow for their use in early and late stages of diabetes. They cause weight loss, which is a desirable effect. Long-term outcome studies are necessary to assess the risk of cardiovascular events. This slide shows comparison between the different anti-diabetic drugs used for treatment of diabetes, with their effects on HbA1C measurement, hypoglycemic effect, if they produce hypoglycemia or not, and their effect on the weight of the patient, if they cause weight loss or weight gain. For example, metformin reduces the AC1 by 1.5%, does not cause hypoglycemia, and causes weight loss. Sulfonylurea also reduces A1 by 1.5%, causes hypoglycemia and body gain. So from this table we can see that sulfonylurea, glenides and thiazolidine ions all will cause increase in body weight, while metformin and SGLT2 inhibitors will cause weight loss. Compared to other drugs, they will lower AC1 by 1% without causing hypoglycemia and have the advantages of causing weight loss. Thank you. Thank you. 0.5%.